Greetings and welcome to Module 6 of the 2021 Geneva Foundation for Medical Education and Research e-course on adolescent sexual and reproductive health in the Eastern Mediterranean region. My name is Marina Plesons. I work with the WHO's Department of Sexual and Reproductive Health and Research in Geneva, Switzerland, and I'll be sharing the global portion of this slide set. Before I get started, I'd just like to thank the contributions of my colleagues Dr. Chandramouli and Dr. Amayan. Thank you. As usual, we'll start with a few key definitions about the topic of the module. First, human immunodeficiency virus, or HIV, is a virus that targets the immune system and weakens the body's defense system against infections. Antiretroviral medicines, or ARVs, are medicines that can be used to treat HIV. They can be used for post-exposure prophylaxis, short-term treatment started as soon as possible after exposure, and pre-exposure prophylaxis, that is for people tested negative for HIV but are at high risk of infection. Finally, antiretroviral therapy is also known as combination antiretroviral therapy or highly active antiretroviral therapy, is the use of a combination of 3 or more antiretroviral medicines to treat HIV infection. It involves lifelong treatment. So what is the rationale for addressing HIV prevention and care among adolescents? So the first point is that HIV among adolescents is an important problem, especially in sub-Saharan Africa. There are 1.7 million adolescents living with HIV worldwide, 88% of whom live in sub-Saharan Africa. With 170,000 new HIV infections in 2019, adolescents account for about 10% of new adult infections. However, it's notable that in places like Eastern and Southern Africa, about 4/5 of new infections are among adolescent girls. This is underpinned by gender inequalities and harmful masculinities, violence, poor access to education, and employment. The second point of rationale is that HIV among adolescents has major health consequences. AIDS-related deaths have declined in 10 to 14-year-olds, largely due to the impact of prevention in mother-to-child transmission, or PMCT. AIDS-related deaths in 15 to 19-year-olds, however, have continued to rise because of growing autonomy and its impact on treatment adherence. Compared to children and adults living with HIV, adolescents have higher rates of mortality. Continuing with the thread of the rationale for addressing HIV among adolescents is the third point, that HIV prevention and management services have been shown to be effective. Packages of effective interventions are available for HIV prevention in adolescents and young people and for key populations within the age group. Similarly, packages of effective interventions are available for their treatment and care. However, taking all this into account, prevention strategies and their implementation and access to high-quality services still need attention. These effective interventions simply are not reaching the many adolescents who need them. A word on human rights obligations related to HIV prevention, treatment, and care for adolescents. First, states are obliged to ensure adolescents have access to confidential HIV testing and counseling services, as well as to evidence-based HIV prevention and treatment programs, critically by health personnel that acknowledge the rights of adolescents to privacy and non-discrimination. Second, states must ensure that the right to health is not undermined as a result of discrimination, including because of their HIV status. And third, that removal of barriers such as third-party consent requirements are also a part of states' obligations. So what are the key concepts to consider in the provision of HIV prevention, treatment, and care services to adolescents? First is that despite enormous efforts over the past few decades, many adolescents still do not know how to prevent HIV or where to access HIV preventive services. Many adolescents, especially those in key populations, don't know their HIV status. And a big part of the reason for this is that adolescents still find it difficult to reach and obtain HIV prevention and care services. Even when they are able to reach and obtain HIV prevention and care services, those services are often still not adolescent friendly. And what does it really mean to be adolescent friendly in the provision of HIV treatment, prevention, treatment, and care services? So with regard to diagnosis and post-test counseling, Receiving information about potential HIV exposure may be more challenging for adolescents than adults, and they may require additional support to come to terms with their diagnosis. With regard to treatment, frequent clinic visits, time spent waiting for services, and having to miss school often discourages adolescents' engagement in care. And finally, with regard to disclosure, this potential loss of social or economic support or loss of a partner may be especially difficult for adolescents, particularly if the partner is older or has more power in the relationship. There are a plethora of WHO guidelines on HIV prevention, treatment, and care, including with specific recommendations for adolescents. As you can see on this slide, at the top, there are a few consolidated guidelines that have been published in recent years to bring all of the various recommendations together into one place to make it easy to understand what WHO's recommendations in this area are. Those include consolidated guidelines on HIV prevention, testing, treatment, and service delivery, which is expected to be published this year. The next is consolidated guidelines on HIV testing services, which was published in 2019. Then there's the consolidated HIV strategic information guidelines, which were published in 2020, and the consolidated guidelines on HIV prevention, diagnosis, treatment, and care for key populations, which was updated in 2016. Now, all of these consolidated guidelines encompass a number of these specific guidelines that you can see in black below. I'm not going to repeat them because it's quite a long list, but you can see that there is a wealth of information available. Then there are some particular WHO guidelines that focus on key aspects or something a little bit different than what's in the main consolidated guidelines. So for example, there's a specific guideline on HIV in adolescents that provides guidance for HIV testing and counseling and care for adolescents living with HIV, with recommendations for a public health approach and considerations for policymakers and managers. That was published in 2013. Additionally, there's a few others like integrating collaborative TB and HIV services within a comprehensive package of care for people who inject drugs, consolidated guidelines on sexual and reproductive health and rights of women living with HIV, and responding to children and adolescents who have been sexually abused. Those are clinical guidelines that were published in 2017. As with all of the other modules in this e-course, all of the WHO guidelines are available on WHO's website. And most of these, if not all of them, are available in multiple WHO languages. In addition to the guidelines that we just saw on the last page, there are a number of complementary documents to WHO's guidelines that are really useful for different aspects of HIV prevention, treatment, and care for adolescents. The first, for example, is the Adolescent Friendly Health Services for Adolescents Living with HIV, From Theory to Practice, published by WHO in 2019. The second is Adolescent HIV Testing, Counseling, and Care, Implementation Guidance for Health Providers and Planners, HIV Strategic Information, Accelerating Progress on HIV Testing and Treatment for Children and Adolescents through Improved Strategic Information, HIV Prevention Among Adolescent Girls and Young Women, putting HIV prevention among adolescent girls and young women on the fast track and engaging men and boys, Learning Session on HIV-affected adolescent mothers and their children in Sub-Saharan Africa, that's a meeting report, Key considerations for differentiated antiretroviral therapy delivery for specific populations, including adolescents, the importance of sexual and reproductive health and rights to prevent HIV in adolescent girls and young women in Eastern and Southern Africa, clinical manual for male circumcision under local anesthesia and HIV prevention services for adolescent boys and men, and finally, WHO implementation tool for pre-exposure prophylaxis. Now, given that there's so many resources available, these have all been put together on a toolkit on WHO's webpage, and we will be sharing that in the information as a resource that's available for your use. As usual, we'll end with a quick cartoon that illustrates a clinical situation of relevance to HIV prevention, treatment, and care for adolescents. Here you see an adolescent boy saying, "I can't keep taking these medications. They're making me feel terrible." And the health worker with empathy and respect is saying, "I understand that this can be difficult. Let us work together to find a solution. Would you be interested in joining a group of young people who are facing similar challenges?" We're going to see some of these, the aspects of this clinical encounter illustrated in some of the case studies that you'll read in the course of this module, and I hope you find them interesting and relevant to your use. Thank you.
Greetings all. This is Dr. Lamia Mahmoud. I'm the Public Health Specialist in the World Health Organization office in the Sultanate of Oman, based in Muscat. Through this presentation, I would like to complement your learning on the module HIV Prevention and Care by delivering the regional perspective for the Eastern Mediterranean. Let me start on a positive note. The HIV prevalence in the Eastern Mediterranean region happens to be the lowest in the world. According to the 2019 estimates, approximately 1.1% of adults aged 15 to 49 years are living with HIV in the Eastern Mediterranean region. On the slide, on the left side, the figure shows the prevalence and compares the Eastern Mediterranean region to other regions of the world. And it reaffirms the fact the Eastern Mediterranean region has the lowest prevalence, whereby 420,000 adults reside in the Eastern Mediterranean region out of the 38 million people living with HIV globally. Again, the same slide shows that the highest prevalence is in Africa, accounting for 25.7 million people living with HIV. On the right side of the slide, you will see that it delves deeper into the statistics for the Eastern Mediterranean region and shows us that the number of cases has been rising since 2010. In fact, there is a 47% increase in the new diagnosis annually as compared to the 2010 figures. Moreover, there is a 57% increase annually in the number of deaths as compared to 2010 also. Now, let's look at the policy situation. An assessment that was done to look at the reproductive, maternal, newborn, child, and adolescent health policies in countries of the region, done in 2019, has shown that 12 out of the 16 responding countries have a national policy or a guideline for STIs that does include a recommendation on integrating HIV and STIs testing. Moreover, an assessment done by WHO Eastern Mediterranean Regional Office has also shown that 20 out of the region's 22 countries have adopted the WHO HIV test, treat, and retain policy. Now, looking at the figures, although yes, the general population living with HIV is low, we note that key populations in the region continue to be disproportionately affected. So we see high rates of HIV among people who inject drugs, and we see these high levels in many countries of the region. For instance, in Pakistan it's 21%, in Iran it's 9.3%, in Morocco almost 8%, in Afghanistan 4.4%, Tunisia 3.9%, and Egypt has 2.4%. Also, the HIV prevalence is also high among men who have sex with men. And this is estimated to be 12.6% in Lebanon, 5.7% in Morocco, and 1.4% in each of Sudan and Tunisia. There's also a high prevalence among sex workers, and this was estimated to be almost 13% in Djibouti, followed by Somalia at 5.2%, Egypt 2.8%, and Pakistan 3.8%. With regard to antiretroviral therapy, ART, the statistics show that EMRO, or the Eastern Mediterranean region, continues to demonstrate the lowest ART coverage. And this was shown that in 2019, the coverage stands at 24% for the general population and 23% for children. However, this masks the variations among countries. We see that there is high ART coverage in the low burden countries. So in Morocco, it's 65%, Lebanon, 63%, Oman, 61% of ART coverage. And this is also seen in most of the Gulf countries. However, we see that the high burden countries, such as Pakistan, Sudan, and Iran, have comparatively lower coverages, whereby an average of 1 in 4 or 1 in 5 have access to ART. So what are the challenges that the Eastern Mediterranean region faces? Stigma. Stigma is rife in the region, whether it's related to HIV itself or to the key populations who are disproportionately affected by HIV. And as you're aware, this presents a major obstacle to the uptake of services. The lack of political commitment is well demonstrated and clear in most of the low-income countries in the region, where we note that the HIV response is largely dependent on external donor funding. This reflects the limited political commitment and the low priority that is given to HIV in these countries. Further, the political developments in the past decade in the Eastern Mediterranean region have not been conducive to decriminalization or the destigmatization of HIV. The limited access to services is also an issue, and we note that for the majority of people living with HIV in the region that do not have access to HIV testing, the analysis has shown that the treatment gap is due to the testing gap, in fact. Furthermore, for many adolescent girls, we note that there is gender-based discrimination that further prevents their access to services. Then there is the issue of lack of integration and the concerns about confidentiality. And this is brought about by the current service delivery models. There is lack of integration, there is centralization of services, and if this is addressed such that services are more integrated, such that they are decentralized, this could improve the acceptability of services for HIV as well as other stigmatized diseases. As a result of this centralization, we see that key populations or adolescents, they're often reluctant to use the services for fear of the HIV status being exposed to the communities when they approach these standalone services. Then there is the issue, of course, of disaggregated data that is evident in many countries of the region. There is lack of sex and age disaggregated data in the routine information management systems. And we need this data because it helps us to see who is receiving the care, how are the existing services meeting the needs or even not meeting the needs. And this is important to inform the evidence-based decision-making processes in the country. Now, I'd like to mention a few success stories from the many best practices that do exist in the Eastern Mediterranean region. The first one was implemented by the Egyptian Family Planning Association, and it focused mainly on young people. The association used outreach services as an extension to its clinical services in order to engage with young people who are most at risk of acquiring HIV. So the strategies adopted were outreach activities through peer educators to extend the reach of health services, as well as advocacy, because they aim to influence policy change that would help in prioritizing the sexual and reproductive health needs of young people within the Egyptian national health system. The services delivered were by peer educators, mostly in the ages of 18 to 25, and who were trained on many aspects, including sexual and reproductive health, HIV, STIs, and communication skills. And these peer educators were responsible for conducting outreach sessions for young people who were less than 18 years of age. And this was primarily at orphanages and government institutions for street children to make sure that they reach all. The peer educators explained to these young people the services offered, made them aware that these services do exist there for them, encouraged them to use the services as needed, and distributed condoms. And these sessions were offered at a location that is away from the clinic to encourage the participants to come and to preserve the confidentiality and avoid the stigma associated with seeking HIV services. It has shown significant achievements. In 2012, the 81 peer-to-peer sessions that were conducted helped in reaching almost 2,300 people, 1/3 of whom were from the key populations, men having sex with men or young people who inject drugs. The second regional initiative that I would like to mention is the one implemented by the WHO Eastern Mediterranean Regional Office. And this was mainly by developing a tool that will help to assess the barriers to HIV testing, care, and treatment. This was done in 2014, and it's called the Test, Treat, Retain tool. And the purpose of the tool was to guide healthcare providers in using qualitative data. And the use of the qualitative data was mainly to assess the determinants and extent of engagement of people living with HIV along the continuum of diagnosis and care. The tool also helped to highlight opportunities to improve access to HIV testing by identifying missed opportunities, of course, strengthening linkages to care, and supporting patient retention in lifelong treatment. Significant achievements were also shown here. 6 countries have adopted this, and they've carried out the Test, Treat, Retain cascade analysis. These countries were Egypt, Iran, Lebanon, Morocco, Punjab province of Pakistan, and Sudan. And the work didn't stop with implementation of the tool in follow-up to the analysis that was conducted. And again, with the support of the WHO Eastern Mediterranean Region Office, these countries have now developed testing and treatment acceleration action plans, and they're now even implementing these plans. And furthermore, with the support of the WHO office, they have also updated their HIV treatment guidelines in line with the latest WHO recommendations, and they have adopted these guidelines at the national level. Let me also end with a positive note and talk about opportunities. An opportunity exists with the existence of a regional strategy for health sector response to HIV 2016-2021. This regional strategy was developed by the WHO Eastern Mediterranean Region Office in consultation with the stakeholders, and it presents a significant opportunity for the region to align with the commitments made by the UN General Assembly. These commitments were made in 2001 and 2006, and also for the strategic directions for achievement of universal access to HIV prevention, treatment, care, and support that was developed by WHO and UNAIDS. These strategic directions focus on the following areas: maintaining and improving coverage of optimized treatment among people living with HIV, tailoring programming to improve access and uptake of services, mainly prevention, testing, and treatment for key populations, re-engaging those lost to follow-up, enhancing health information systems, and continuing advocacy and resource mobilization. With these strategic directions being implemented, we can guarantee achievement of universal access to HIV prevention, treatment, care, and support. With this, I end my presentation. The next slides reflect the references from which these statistics and information have been taken. Thank you for your attention.